we go. Forgot to bring my clicker today. So, all right. Development of the nervous system. Okay, speaking of development, okay, one of those is me and one of those is my son. So you got to guess which one is me. Is it the left or the right? Is it just because it looks like a grainy old picture or something like that? So, or is that, do I look that mangle? I got that droopy eye or what? It's, yeah. 1968 was a good year. All right, so let's talk about developmental stages in utero. And this is kind of are you guys talking about some of this in there we got maturation science? So this should hopefully complement some of those things. So some review, hopefully. Stages, pre-embryonic stage, okay? Conception to 2 weeks, first 2 weeks after conception. You get that solid sphere of cells is formed. A cavity opens up in that sphere, and that's when we call it the blastocyst, okay? It implants into the endometrium. The inner cell mass develops into what's called the embryonic disc. And then you get eventually first 2 layers, an endoderm and an ectoderm, okay? And then you eventually form a 3rd layer, mesoderm, okay, in between the endoderm and ectoderm. So here's trying to show or represent that for you guys. You got your picture on your left of the book, okay, showing this. Here's the blastocyst right here that develops. You can start to see our ectoderm and endoderm layers developing here. Here it's again a little further development, ecto and endoderms. This down here, this yellow, is the yolk sac, okay? And this red becomes your amniotic cavity, okay? And so the next picture down here, right here, this is looking down at the top of that embryonic disc. So this is the embryonic disc, and they basically cut off the amniotic sac there. They've, cut the amniotic sac right here. So you're seeing the edges right here of the amniotic sac is what you're seeing in that particular view. If you look at the picture on your right there, that gives you a little more of appreciation. So what happens as this fetus starts to develop. I had the hardest time. Your book doesn't do a great job of showing pictures that give you that good 3-dimensional perspective of what's this fetus look like, how is it forming. And so here's that. Let me go with a little lighter color here. Here is the embryonic disc here developing. Here's that amniotic cavity and the yolk sac. And you can see, as you see continued development, that amniotic cavity gets bigger while the yolk sac starts to get smaller. And eventually, the amniotic cavity is surrounding the embryo here that's developing, and the yolk sac is shrinking up, okay? You can start to see the gut and the organs developing in here from the endoderm. So that's what you're seeing there as the embryo in development, okay? That helps. Moving on to the next stage is embryonic stage, 2 to 8 weeks. This is where we have our 3 different layers of tissue that are starting to further subdivide and develop into their organs and tissues. So the ectoderm is going to be your sensory organs, your epidermis or skin, and the nervous system. So key, star, nervous system is from ectoderm, right? So nervous system, ectoderm. Mesoderm is going to be your dermis, okay, a little deeper level of your skin, okay. The muscles, skeleton, and then excretory and circulatory systems. Then endoderm, sort of makes sense, gut, liver, pancreas, and respiratory systems, okay. All those systems that kind of have some tubular features and so forth. This is just another picture showing the embryo developing here within the amniotic cavity, and then this yolk sac down below. So, fetal stage, 8 weeks until birth. So lots happening in the first 8 weeks. So we're getting a lot of differentiation. So from the fetal stage is 8 weeks until birth, and that's why it's so critical that women are knowing that they're pregnant and can make the right choices and have the right nutrients while they're going through that very early stages of development. Nervous system develops more fully, and myelination starts to begin during the fetal stage. Doesn't complete, your actual myelination doesn't complete until you're 3 or so years old, 3 to 5 years old is when you have full myelination of your nervous system. All right, so now that's just basic embryonic development stages. Now we're going to go through specifically nervous system development through those stages. Okay? So the first thing that occurs is with this neural tube formation. Okay? This is about day 16 is when neural tube formation begins. The first thing, though, that occurs that kind of starts this process of developing the neural tube is this thing called a notochord develops. Okay? So the notochord arises out of the axial mesoderm. Okay? So some of the mesoderm, that middle layer, some cells differentiate and turn into this thing called a notochord. Okay? This notochord runs along the longitudinal axis of the embryo. So this little notochord is like a piece of licorice or whatever you think about, through the middle of the mesoderm that represents a longitudinal axis of the embryo. It completely forms by 4 weeks. It starts the process of induction, which is induction is where you kind of get the edges of the ectoderm pulling down into the mesoderm to start create the tube. And I'll show you a picture here. So it gets the overlying ectoderm to form the neural plate and then become the neural tube. Interesting little fun fact is the notochord ends up being the nucleus pulposus. That's what's left over is the nucleus pulposus in your intervertebral discs. Okay, so the thing that causes herniations and those kind of things is your notochord. Basically, you have a herniated notochord that's pushing on your nerve or something like that. So that's just kind of interesting. So we're looking here. So this would be the so we'll go back to a different color. So our embryo would be like this. Okay, so this is the embryo, and this is ectoderm. You know, this outside here is ectoderm. This is all mesoderm here. And this is that differentiation of cells called the notochord. Just a little becomes a notochord. And that causes this process to initiate called induction, where the ectoderm, that thickens right here and becomes the neural plate. That thickening of the ectoderm is the neural plate. And then as it starts to get pulled in, like kind of like a notochord's like a magnet drawing it in, that's induction. Okay? So it's A, and then B. You can see it goes even further, really drawing it in here. And then eventually it closes off. Okay? You'll see these little neural crest cells, because they're right on the crest there, or edges of the developing neural tube. They end up being eventually drawn in here into the mesoderm, but they still came from ectoderm. Okay, so when we get to, we'll talk about, these end up becoming your spinal nerve ganglion, the dorsal root ganglion. Your sensory spinal nerves are coming from that. Okay, but they started out, all the nervous system comes from the ectoderm. And so even though these got pulled on to the mesoderm, and now we see this neural tube developed inside of the mesoderm, but it all came from that neural plate and that ectoderm. Okay. So here's your book's picture showing that same process. We're starting to show that same process. So here's the thickening. It starts to get a little thicker here, not real thick yet. This is the ectoderm. Here's our endoderm, mesoderm in here. And remember, this is going to be our amniotic sac, and down here's our yolk sac, what they're showing there. And then this is a superior view looking down at the top here of this embryonic, of the neural plate being developed here. So focusing on this neural tube formation, okay, the notochord develops about day 16. The actual neural tube formation starts where it first touches about day 18 and then continues to zip closed up to day 26. So you get the longitudinal thickening of the ectoderm called the neural plate. The edges of the plate fold to create the neural groove. Okay, so we get that groove first. When the edges touch, which is day 21 actually showing here, the edges first touch in one spot along the embryo, that's when we get the neural tube formation. The tube closes first in the cervical region, okay? So it's kind of like up around C7, C6 is where those first edges touch. And then it zips rostrally and caudally, kind of like a Ziploc baggie. They start to, those edges of the neural tube meet, and the neural groove meet and form the neural tube, okay? Cells adjacent to the neural tube form those neural crest cells, little red cells I showed you that kind of came in. That's the neural crest cells. Then the neural tube moves down inside that mesoderm into the into the embryo, and then the superior neuropore closes day 27. Superior, that's where the actual cerebral cortex and those hemispheres join together, is day 27. And then the inferior one, down the sacral level, closes a couple days later, 3 days later. Then you start to get your differentiation of the neural tube into two layers, the mantle or gray matter, the mantle layer and the marginal layer, okay? And that starts to about day 26. So you can, the key here is that it's all happening before day 30. This is all happening before the first month. And that's why they say, you know, having those proper levels of iron and those kind of things is really important for nervous system development, because these are such critical things that happen that first 30 days. So here's that showing the neural groove formation here. They don't show here. The notochord would be right here that they don't show in this picture. Here's our differentiation of somites, starting to see some somite development yet. You don't see it from the top yet here because they're not really bulging out. They're not creating kind of bulges here on the side. They're just starting to differentiate. These somites are starting to differentiate those cells. Now we can see, here's day 21, and the neural tube has met here, and we've actually got those joining together in the cervical region and to create the neural tube. Our somites are further developing and differentiating, and now we see this start creating these little bumps on the side of the embryo. So we see the little somites here on each side starting to develop, and then we get the zipping of this rostrally and caudally, the zipping of the neural tube over the next, you know, several days, over the next till day 26 or 28. So here's day 26, almost closed, still a little bit of opening of the neuropore, inferior and superior neuropore. Here is our now, at this point, at day 26, you can see our neural tube is differentiated into two layers. The marginal layer out here and the mantle layer right here. Mantle layer becomes the gray matter. That mantle layer is going to further divide into that motor plate and sensory plate, or that basal plate and association plate, that mantle layer, okay? The gray matter. The white matter, the axons, are the marginal layer. So all the white matter in your spinal cord is coming from that marginal layer, the marginal layer. Remember in our cerebral cortex, though, our gray matter is actually on the outside, okay, versus on the spinal cord, the gray matter is in the inside. But what happens is, so in the cerebral cortex, remember I said those little epithelial cells? So there's a really very, very thin lining right in here in the neural tube. There's the epithelial cells that turn into your neurons, okay? And in the spinal cord, they tend to stay more centrally located, the gray matter, the cell bodies for those. But in the cerebral cortex, they migrate. They actually migrate out and move to the outside to form the cerebral cortex and layer on top of each other. This is just showing you in an electron microscope in a chicken embryo that same process of neural tube formation that looks very similar in human embryos at that point. Relationship of neural tube to other developing structures. So the mesoderm divides into the spherical clusters called somites. These give rise to sclerotomes, dermatomes, and myotomes. Mantle layer, cells proliferate, separating eventually into the motor and basal plates, okay, or the association or alar plate. Okay, so that mantle layer is going to subdivide into the motor and sensory or association plates. Neural crest cells break into segments that correspond to the dermal areas of somites. So these are the neural crest cells right here. That little blue area that came in from those edges, the crest of the groove that was developing that comes in, and these are going to end up being your dorsal root ganglion that are going to associate with a specific region of the somite, of the dermatome of a somite. Okay, so they're going to actually grow these little axons out to innervate that area of skin that's going to eventually develop that dermatonal area of skin as the embryo develops. So all I want you to see here, so here we take a look at our neural tube, and here it is further developing here. So now that all this red and blue was the mantle layer, okay? The outside of this is your marginal layer that you're barely seeing right now, any white matter. But the red and blue divide into the motor plate or basal plate and the association or alar plates, which eventually, and this right here, dorsal root ganglion right here that you're seeing, this is your spinal nerve, okay? Here's motor. This is your neural crest cells, okay? Neural crest cells. That's the blue stuff right here. Eventually becomes your dorsal root ganglion. And then there's your somite that differentiates into your different structures, dermatomes, myotomes, and sclerotomes. So day 28, once that superior neuropore closes, once the top of your neuropore closes, that top one, then you start to have brain formation, okay? So this is what, and you know, we're looking at the 3-vesicle, 5-vesicle stage, and then what eventually it ends up as in a baby or an adult mature development. And you can see this cerebrum starts to grow and kind of expands and actually grows over the diencephalon in midbrain, because you're just layering in and growing neurons in that cortex, and also in your cerebellum, in the back of your cerebellum, everywhere pretty much. So let's talk about the cellular development here of the as the maturing nervous system occurs. So you have those epithelial cells that are that very, very inner lining of the neural tube, okay, that line it and divide into neurons and also glial cells. So some of those will differentiate into your supporting glial cells. Neurons differentiate appropriately after migrating to their final location. So they kind of go out and find their final location, and once they get to there, based on what neurons are around them, they kind of test the area, and there's little chemical messengers that these neurons kind of send out, and they realize, oh, I'm in the whatever, I'm in the basal ganglia, so I'm going to become a, you know, basal ganglia neuron, okay, or I'm going to be a pyramidal cell because I'm in this layer of the cortex, or I'm going to be an anterior horn cell because I'm in the motor plate. So then they're kind of doing that based on signals of all the other cells around them. And this is all pre-programmed kind of stuff that occurs where they're going to go. They actually have a little growth cone. As they're trying to find where they're going to get located, they kind of test the area with a little growth cone, and that's kind of, you know, some of those neurofilaments and the actin molecules, those help move and kind of shimmy these neurons around to migrate, and they can actually kind of move around to find their location. Okay. If they don't make appropriate connections, okay, they die off. And part of what makes the connections is sensory experience and input to the nervous system. So during that first 3 years of life, when you haven't fully myelinated, that's that critical time when a baby needs appropriate, you know, interaction, sensory experiences, development, motor experiences to develop those connections, because if they don't develop, they may never have them. So these, you know, you hear these, you know, horrible stories of kids in orphanages that don't get any attention for years, and they never have a fully mature nervous system. That you've lost that window to develop those connections and all those little dendritic spines and the, you know, complexity of connections you're looking for. However, over time, with input, you have neuronal sculpting. So sometimes, you know, as you use one system more, or you have different sensory or motor experiences, you shape your nervous system. It's neuroplasticity, essentially, a neurosculpting that, you know, even in a normal baby who has normal sensory and motor experiences and input, they will still have sculpting going on that affects their development. Cellular level development continued here. So myelination begins in the 4th fetal month. So this is where we start to get the insulation. Okay, we got the oligodendrocytes and Schwann cells, oligodendrocytes in the central nervous system, Schwann cells in the peripheral that are starting to form the myelin. Okay, which helps support the nerves so that they can generate faster, you know, conduction and those kind of things. Occurs at different rates for different parts of the nervous system. Most myelination is done about age 3. It's mostly completed by age 5. So clinical interest is sometimes you'll see babies that they call growing into deficit. You don't know they have a problem until they don't meet a certain milestone. So they kind of grow into deficits is what they call that, when like, oh, they should have been able to do this at age 2 or 3, but they're not because their nervous system isn't maturing. But you don't know that until they get to that milestone and aren't meeting those normal developmental stages. Just another clinical interest. So there's a thing called the Babinski sign where you scrape the bottom of the foot. You look for the big toe. If it goes, big toe goes up, the other 4 toes kind of splay out a little bit. In an adult, that's abnormal. That's indication upper motor neuron problem, like brainstem, or spinal cord has a problem in it. In a baby, before the age of 3 months, that's because they're still not fully myelinated. That's part of it is they're still having myelination done of those pathways. And so when you do that to a baby, after 3 months, most babies have the normal response for an adult is the big toe goes down a little bit, and the other toes do a little, kind of like a little flex, just a real brief little flex as well. So the big toe goes down, where the abnormal response is big toe extends, and the other toes splay out like that. So, which is they're showing that right there. All right. Doing well. You guys doing okay? Any questions or anything like that before we do let's do a quick here, take 10 minutes, and then we'll come in and wrap things up and talk a little quickly about the exam for Friday. Go back to here. Okay. So first class of problems we're going to talk about is neural tube defects. Okay, so problems with the neural tube forming or closing. The first and most severe is this thing called anencephaly. Okay, so this is where you might have formation of a rudimentary brainstem, but without cerebral or cerebellar hemispheres. Okay, so this is a failure of that rostral neural pore to close. Okay, so you don't get that closure. Occurs when the cranial end of the tube remains open. Most fetuses with this condition die before birth, okay, in utero, and almost none survive more than a week after birth. So there's a picture here showing the anencephaly, and you can see here there's the rudimentary brainstem there protruding through. The skull doesn't close either in this case. So they may survive a few hours, but that's about it. This is different than what's occurring now in South America with the Zika virus. Have you seen now this virus is spreading by mosquitoes that causes microcephaly? So those children usually live, but they have a much smaller head and a more poorly developed cerebrum, but it still closes. But that's pretty scary. They're actually telling women in El Salvador to wait 2 years. They said don't get pregnant till 2018. They're trying to get them all not to get pregnant until 2018. Yeah. Uh-huh. Yeah. No, it's not. It's usually not bleeding, but it can be more damage can occur if they're being delivered vaginally. But they usually know that the baby isn't going to survive anyway, so it's kind of one of those things. So another issue is this thing called the Arnold-Chiari deformity. This is where the inferior cerebellum and medulla are elongated and protrude into the vertebral canal. So it's a neural tube defect, but it's not a failure to close. It's just that the way that when the nervous system is developing, you get this more elongated cerebellum and medulla that go down into the foramen magnum. And I'll show you a picture here that shows that. Often associated with hydrocephalus. So it actually, what happens is because of the bottom of the cerebellum and the medulla getting squeezed down into the foramen magnum where it goes out of your skull, it squeezes off the cerebral aqueduct. And that closes the cerebral aqueduct and blocks the ability of your cerebral spinal fluid to get out. Remember, there's a couple holes in the bottom of your cerebellum where it gets to the outside of your nervous system, where it comes out. Those get blocked off, so it all backs up inside of the lateral ventricles and the third ventricle and so forth. And if you have your brainstem being pushed on by the skull or around it, it can often impact some of the cranial nerves that exit right around that same area, which happens to be eye, for the abducens or lateral rectus muscle of the eye, some facial weakness, cranial nerve number 7, deafness, cranial nerve number 8 that can be impacted, all exit around that same area of the pontomedullary junction that gets squeezed in this particular region. So here is the Arnold-Chiari malformation. There's some green dots here. I'm going to make a red line here. This is where your foramen magnum is. So normally the cerebellum should be contained all up above that, but here you see this inferior lobe or tonsil of the cerebellum protruding down into the below the foramen magnum, and then that causes pressure here to build right around that area, and too much pressure that squeezes on both the brainstem right here. Just here's the pons and here's the medulla, but any of the cranial nerve nuclei or cranial nerves that exit around this area have a chance to get pushed on or impacted and damaged. In addition, you're blocking here. Here's the fourth ventricle back here, and then that cerebrospinal fluid is going to come down and try to exit down underneath that cerebellum, but it can't. It's getting squished. So then you get hydrocephalus. If you do have hydrocephalus, where you get the backing up into these lateral ventricles, they have to put a shunt in. Okay, they have to find a way to get it out of there. So what they do is they actually put this small little tube or catheter that is inserted in the lateral ventricle, and they place it through your brain in an area that's not known for very specific function. You know, there's always a risk you can cause a functional deficit or problem, but they try to miss the most vital regions of the brain where they insert this catheter, and then it's got a little, then this little tube here runs down. You can feel it if you've had, you know, anybody that has this, that has a catheter. You can actually, if you feel through their skin, you can feel the tube running down. It goes into their neck, down just underneath their clavicle or just over the clavicle, and then down to the peritoneal cavity, and then run it down. It just dumps into your peritoneal tissue and just gets reabsorbed there is where that occurs. The problem is that there's some proteins inside of your cerebrospinal fluid that eventually it always clogs up. You know, eventually gets clogged up, and the problem is they got to replace those drains, and every time you go in to replace a drain and do that, there's a chance of infection and chance of complications. And so I've seen older adults who've had issues because of trying to have that replaced, or if they leave it blocked too long and that causes pressure and can cause some damage in the brain before they replace it, it can be an issue. And you'll notice they leave a long tag end down here. So why do you think they leave it longer? So as the baby grows, you know, as the child develops, that has room to lengthen. Another big area of neural tube deficits that you may have already, have you guys talking about any of these at all in your maturation science? Are you just doing normal maturation right now, or are you talking about some developmental disorders yet at this point? No. What's that? Okay, so spina bifida is a neural tube defect, and that's the inferior neural pores. So the caudal end fails to close or doesn't close properly, and sometimes then the developing vertebrae around it does not close. Okay, there's a couple different classifications or severity of this, and there's 4 different ones here. So the one that's the least problem is called spina bifida occulta. Okay, this is where the neural tissue develops normally. It doesn't protrude through this defect, but you don't have full completion of the vertebral arch. They may be missing their vertebral arch. The spinal cord, the dura, everything's intact, but they just don't have a fully developed vertebral arch. The vertebrae doesn't fully cover it. And sometimes there's a telltale sign is that they have usually a little tuft or patch of hair right in their lower lumbar spine there. That's pretty prominent. Not everybody that has that has spina bifida occulta, but some people do. About 20% of the population has this. Okay, so it's a pretty high percentage. It can lead to pain or problems for some people, not everybody. So you may be working in an orthopedic clinic, and the X-rays come back, and you may see that spina bifida occulta, and maybe their vertebral arch didn't form right. Maybe the facet joints down there aren't quite right, so that could lead to pain or problems. Just something to be aware of. The next level of involvement is called meningeocele. Okay, this is where the meningeo, okay, which is going to be basically your dura and arachnoid. Okay, the coverings of your spinal cord protrude out through the defect. Okay, they may have impairment, but they may not have impairment with this. Okay, so they may have actual weakness, motor weakness, or spasticity, or something like that. but they may not, depending how severe it is. The next level of involvement is meningio-myelocele. Okay, so the meninges, meningio, myelo, M-Y-E-L, refers to, it's like myelin, but it's in this case, it refers to the spinal cord. If you hear that, that's spinal cord, right? So the meningiomyelin, so this is where the meninges and neural tissue, including the spinal cord, protrude, and there's generally always some degree of lower body dysfunction with this, okay, some type of lower body dysfunction. Then the most severe, kind of like with anencephaly on the cerebral or rostral side of things, is this thing called myeloschisis, where you actually, a schism or schisis, it's open, okay, where they actually have the spinal cord, it never closes, the skin doesn't even close, they've got this exposed spinal cord tissue at the, caudal end of the spinal cord. So good old Netter has some nice pictures of this. So here is spina bifida occulta. So you can see this lack of full development of the vertebral body, or vertebral arch, I should say. The vertebral body is okay. And you can see here, you don't see a good strong x-ray, showing the vertebral arch there. And that's spina bifida occulta with a nice little hairy patch back here. Okay, some little fatty infiltrates there. Here is the meningiocele. So here's the meningiocele. So here's your spinal cord here. But then here's the arachnoid and dura going into this open kind of, cystic-looking structure on the back here, okay? And the pia is part of your meninges too, but the pia is that microscopic layer on the spinal cord. So it's just the dura and the arachnoid that are ending up in here. And like I say, this may not cause a problem, but it could cause a problem. So it just depends on how severe, how big that opening is. If there's a few little nerve fibers that get out there with it, a few spinal nerves that get in there with it, okay? Now here is the meningiomyelocele, okay? And this is where you have the actual, here's a spinal cord and the cauda equina actually inside of that cystic, area there that, and that definitely is making it exposed to having potential damage. Are they doing work on the other side of it? I guess so. It looks a little rough in here with like the insulation hanging down, like wires hanging out of the wall over there. I don't want to bring anybody to tour around. You guys are all the tuition you're paying, and we can't even barely keep the lights on. And then here we have some opening where it's exposed, that myeloschisis, okay, where you actually have exposure of the nervous system tissue. They actually now do. They're doing some of these surgeries in utero, going in and trying to protect that and do a surgery well before the baby's born, because it's during the birth process that some of that damage occurs. So if they can catch it, get that thing pushed back in and seal it up and take care of it before birth, then there's a chance they can preserve some of that function. Forebrain malformation. Okay, so there's so we're talking forebrain. Prosencephalon, forebrain, cerebrum eventually. There's a problem where you can actually have that fails to divide normally, so you don't get the two split hemispheres, okay? And you actually get failed to divide even of facial structures to varying degrees of facial abnormalities. The most severe is this thing called holoprosencephaly, where you have failure of both brain and midline structures of the face to divide, okay? These babies or fetuses don't survive, okay? They suspect maybe a mutation of the sonic hedgehog gene is one possible cause, so I don't know where they get these names for these different genes, these nerdy scientists that come up with these things. But there's a very severe form of holoprosencephaly where there's failure to divide of facial features, and actually if you looked in their cerebrum, you wouldn't see two distinct cerebral hemispheres. It'd just be one mass of this forebrain or prosencephalon. Other things that can cause problems for the developing nervous system are any kind of exposure to alcohol, cocaine, heroin, other major drugs in utero. So people have maybe heard of fetal alcohol syndrome that can impair CNS maturation. It can cause growth deficiencies, facial abnormalities. I need to change this archaic term. We need intellectual disability, okay? So I think your book has now changed its terminology. This was back from like 3rd edition. Um, Cocaine abuse can also interrupt disturbance of neuronal proliferation. So as you're trying to create new neurons and proliferate neurons and get them to the right places, it can interrupt that process because cocaine goes right through that placenta very easily, so it can affect the fetus very easily. And it stays in fetal circulation for quite a while once it's in there. So this is just showing you some of the typical characteristics of some of the facial features you might see of a child who has fetal alcohol syndrome. So if you're working in a pediatric setting, you're going to see some children with developmental delay who have fetal alcohol syndrome, and you can usually kind of see this characteristic facial features, you know, this kind of wide space between the eyes, a little more of a flattened face and features, and some maybe ear abnormalities and so forth. So intellectual disability is the next one. So just all kinds of reasons, and then some they don't know, can cause problems with development, especially the morphology and development of the dendrites, and then dendritic spines is where they're thinking a significant amount when you look at after death and under a microscope you see that the dendrites are not only not as prolific, not as many dendrites, but the little dendritic spines that really allow for much more connection points to occur. There's less of them. So that's one reason why they have the intellectual disability. Now, why they have less dendritic spines, there could be genetic causes, there could be environmental causes, different things like that that can cause a variety of these intellectual disorders, developmental delays. Cerebral palsy, so CP is the big catch-all term to describe really almost non-progressive damage to the nervous system while, at the time of birth or before birth, okay? And typically it's because you've had some kind of disruption of blood supply or oxygen to those nervous system tissues. So in an adult, we're talking like somebody with a stroke or something like that typically occurs. In a child, if they had a stroke, while in the womb or at the time of birth, they usually call it cerebral palsy that they have during that time, even though it's due to some lack of oxygen, blood supply to nervous system tissue that causes damage. And just like we have different characteristic types of presentations, whether we have a head injury versus a stroke and you have one-sided weakness, you can have similar presentations in cerebral palsy, and they kind of classify them under kind of three main categories, then a mixed category. So they have spastic, okay, it's primarily spastic cerebral palsy. This typically occurs when you have damage around the ventricles and the descending white matter tracts. Part of what we call the internal capsule goes right down past the lateral ventricles. You damage those, they tend to have this very spastic cerebral palsy, and it could be, quadriplegia, diplegia, could be in all four limbs, could be just more in the upper body, could be more in the lower body, more one side than the other, but they're very spastic in nature, and they hold these kind of sustained tonic postures, and you tap on their tendons, and they're very spastic, okay? That's spastic. If they have damage to the basal ganglia structure, so lack of blood supply to the basal ganglia, they might see this thing called athetoid type cerebral palsy. So athetoid is kind of like they have this writhing, snake-like movements where they're, moving kind of all the time. And they call that athetoid types of cerebral palsy. Ataxic is if they have damage to the cerebellum or connections with the cerebellum. So when they move, you might see these really ataxic, discoordinated movements, But most often you see some combination. So you might have a spastic superimposed with an ataxic, movement kind of thing. So, cerebral palsy is not a childhood disorder because these people now live most of their lives, and you will be seeing them as adults. I see a lot of them in the neuro clinic, and they have, significant issues. A lot of them have worn out joints by that time because if they are ambulatory or moving, they often are walking with very abnormal movements. And we're seeing a big population of older adults with cerebral palsy who need ongoing care and physical therapy. So that's been kind of fun to work with. That they really need our services, and they really value it. Just for curiosity, we'll see if it works here. Somebody sent me a link, and you may have seen this. See if it goes up here. So speaking of cerebral palsy, this gentleman here is an older gentleman with cerebral palsy. Have you guys heard about this guy who's a typewriter artist? You seen that? It's really pretty impressive. But he had cerebral palsy, obviously as a young child. He's a very old man. In those days, they put you in institutions. So he's been living in nursing homes, institutions most of his life. You hear him talk and hear him interact. He's perfectly okay mentally, but it's just sad that he was in those situations. But I hope the volume works here. Quick 4 minutes.
Keystroke by keystroke. He types his latest masterpiece in an Oregon nursing home. But Paul Smith is not an author, he's an artist.
Think about what type of cerebral palsy he might have, ataxic, spastic, or...
He was born with severe cerebral palsy, yet Paul Smith has created hundreds of works of art using a typewriter.
You give me a typewriter, I can't even type 12 words a minute looking at my hand, okay? There is no way that I could come up with a picture like that.
Every time I flip through the one night, it's amazing. Because it's as good as art as you can find.
Paul's movements are severely limited. His determination, endless. His disorder makes using a brush or pen impossible. But as a young man, he discovered the keys to expressing himself at the top of a typewriter keyboard. Using just 10 of the symbol keys, he taught himself to paint. Look closely and you can see how Paul typed pound signs to create the facial detail on his Mona Lisa.
Crazy.
Here, the at symbol doubles for desk drawer knobs in this scene of his childhood bedroom. Note the typewriter prominently displayed. Paul has created incredibly detailed pictures by artistically aligning those 10 keys against a black or colored ribbon.
His joy in life is finding ways to be creative. I think Pete sees it as part of why he's on Earth, why we're on Earth. Well, I think we all have the same.
When someone says, I could never do that, Paul answers, places Paul's lived or visited are the inspiration for much of his art, some of which lines the hallway of Rosehaven Nursing Center. There's a lot of memories on this wall. That's the trip you went to Bermuda on.
See how he's stabilizing his wrist while he moves things?
Family now is the staff and residents of Rosehaven, where he has lived since 1967.
Hey, Paul. How are you doing today? Are you still working on that dog? How you doing?
He's such a terrific person. He's such a humble man, a real gentle soul.
He's really nice.
Oh, thanks, Paul. Continue to be nice.
Paul Smith would much rather brag about his friends at Rosehaven than about himself or his art. And those who know him say the same thing about Paul. The artist is even more inspiring than his art.
It's wonderful to watch him work, and it's wonderful to enjoy his art, but not as good as enjoying him.
Deeply religious, Paul says his artistic ability is a gift from God. His faith and something else keeps him going.
My finger.
And with that finger for as long as he is able, this extraordinary man will continue creating his extraordinary art, one keystroke at a time.
Pretty cool. I keep trying to readjust my thinking about, I hate the word disability. I'm trying to use, instead of disabled, differently abled, because we're all just differently able. There's people that have disabilities that can do way more stuff than I can or smarter than I am. So I'm trying to get that word out of my vocabulary and just go differently. We're all differently abled. So what kind of type of cerebral palsy do you think he might have had, or predominantly based on kind of some of the descriptions or his movements? I don't know if you want to take a guess. I mean, I would probably lean towards more ataxic. The athetoid, they tend to have writhing movements all the time, even when they're sitting. But at rest, you can see he could be pretty quiet and not, as long as his arms are touching something and stabilized on something, you don't see that. But when he starts to move, you see these big amplitude, ataxic, and he's kind of trying to use one hand to stabilize the other. As long as he's like touching a surface that helps stabilize that, that's more of an ataxic type cerebral palsy that you see there. And he didn't have a lot of, didn't look like real severe deformities that you see with spastic. With spastic, they have these very severe deformities, and often their hands are stuck where you can't open their hands, their feet are plantar flexed and those kind of things, so he looked like more of an ataxic type cerebral palsy. That was the link to that. Just summary, major deformities of CNS develop during, often occur before week 20, so those first 20 weeks are really, really important. More minor and localized damage may occur after week 20. So major deformities like where you have, the neural pore doesn't close, or forebrain malformation, or those kind of major, nervous system problems happen those before week 20. Once things are pretty well developed, then you have more localized minor. So maybe they have a little stroke, or maybe they do have some lack of oxygen. So it's they may survive the fetus, but it's not just major disorders sometimes.
Well, the ones that we went over, like detectable before birth.
So it's hard to detect like cerebral palsy before birth. But you can detect like most of the other ones, failure to close the neural pore, anencephaly. Those are all detectable on ultrasound and those kind of things. Yeah. This is interesting. A lot of fetuses don't make it. Okay, and 75% of spontaneously aborted fetuses are due to some CNS malformation. So that's the vast, majority of miscarriages are associated with just probably because the fetus didn't have a normally developed nervous system. So some just quick nervous system changes during infancy. There are certain critical periods that are development where axons are competing for those synaptic sites. This is why it's important to have that enriched environment, during those first 3 years of life when that neuronal sculpting is going on. It's briskest pace, and without proper stim, those connections can be lost forever. And that's it. Any questions? Let me pause this, then we'll talk about the exam briefly.